Welcome back to the Neuroblastoma Parent Symposium. This session is an exciting panel session titled Cell Therapies in Neuroblastoma, and it's going to be chaired by Dr. Naveen Pinto, Principal Investigator in the Center for Clinical and Translational Research at Seattle Children's Hospital and Associate Professor of Pediatrics at the University of Washington. So I will hand over to Dr. Pinto to introduce and chair the session.
Great, thank you, Nick. And thank you to the organizers for hosting this meeting and inviting us to present on this exciting new set of therapies for cancer. I hope you'll find it interesting, and we'll ask lots of questions. I'll start by introducing our panel. First, Dr. Crystal Makel is the Ernest and Amelia Gallo Professor of Pediatrics and Medicine at Stanford University. She's the founding director of the Stanford Center for Cancer Cell Therapy and director of the Parker Institute for Cancer Immunotherapy. She has hundreds of publications and has mentored over 50 postdoctoral fellows and doctoral students. Her work is focused on understanding the role of the immune system in cancer patients, including the role of CAR T cells in treating pediatric cancers. Next is Professor Franco Locatelli, who's the director of the Department of Pediatric Hematology, Oncology, and Cell and Gene Therapy at the Ospedale Bambino Gesù in Rome, the largest childhood cancer center in Italy. He's the co-author of over 1,000 publications, and his current main fields of research are in cancer immunotherapy, gene therapy, and genome editing for rare diseases. He led the first 2 CAR T cell trials in Italy for children with neuroblastoma and acute lymphoblastic leukemia. And last but not least is Dr. András Hexy, who received his undergraduate and medical education at Semmelweis University in Budapest, and then moved to the United States for his training in pediatrics and pediatric hematology oncology. He's currently an assistant professor of pediatrics at Baylor College of Medicine and an attending physician at Texas Children's Hospital. His research focuses on the use of genetically modified NK, NKT, and T cells to control pediatric solid tumors, including neuroblastoma and liver cancers. So thank you all for joining us. I thought I would start off the session by sharing a short 4-minute video prepared by the Leukemia and Lymphoma Society. So I'll give a caveat that this, although talks about leukemia, I think the introduction to CAR T cell technology and the video that Leukemia and Lymphoma Society has prepared, I found very helpful. So we'll start by sharing that video.
At LLS, we always say that beating cancer is in our blood. It's a phrase that captures the heart and soul of what we do. But what if your own blood could actually be turned into a meaner, leaner, cancer-beating machine? Well, that's what doctors and researchers are doing right now with something called chimeric antigen receptor T cell, or CAR T cell therapy. To understand it, we need to start with T cells, a type of white blood cell that patrols our bodies for signs of disease. See, all cells have protein fragments called antigens on their surface. Some antigens are tumor-specific, meaning they're specific to certain cancers. And it is these tumor-specific antigens that ultimately alert your body's immune system, specifically your T cells. See, T cells have receptors on their surface that are uniquely designed to latch onto antigens of cancer cells. They then kill the harmful cells by injecting them with toxins. It's a pretty amazing system when it works. The trouble is, cancer is smart. Cancer cells can disguise themselves so our T cells don't recognize them as foreign. And when that happens, the cancer grows, leaving one of your body's most powerful defenses, well, kind of powerless. So researchers asked themselves, what if we could reprogram a person's own T cells to break through cancer's defenses? And that's what CAR T cell therapy is all about. In a nutshell, the doctor takes out some of your own T cells and sends them to a lab. The laboratory technicians turns them into super cells, CAR T cells. They do this by modifying the new CAR T-cell receptors to recognize your specific cancer and make those receptors, well, more receptive to its antigens. The new cells are reproduced a few million times and then frozen so doctors can begin treatment when the time is best for you. Before you're able to get your new CAR T cells, you'll be given something called lymphodepleting chemotherapy, which will make room for your new super cells. Then, when it's time, your doctor will introduce the new and improved T cells back into your body. The good news is that they start attacking the harmful cells right away. The bad news is that the therapy has a high likelihood of causing side effects and making you sick. Many patients experience symptoms typical to a bad case of the flu. Patients also report nausea, dizziness, and loss of balance, among other symptoms. And make no mistake, in some rare cases, patients can experience more serious side effects like confusion, seizures, and even stroke-like symptoms. Your doctors will want to monitor your condition, so they'll likely require you to stay near a hospital or perhaps even check into one. But for many patients, these side effects are temporary and can be managed with medications or other procedures. What's more, researchers are making great strides in controlling and reducing those side effects. So what happens after the sickness passes? Well, this is the really good part. These stronger and faster CAR T cells just keep reproducing in your body for a long time after the infusion, continuing to fight the cancer if it returns. And in many cases, they continue to work long after a patient enters remission. Right now, this therapy is typically only given to patients with specific types of blood cancer who have not responded to common cancer treatments. And only your doctor can tell you if this therapy is a real option for you. But while the results are early, they're incredibly promising. And encouraging studies for other types of blood cancers are moving forward at great speed. As beating cancer is in our blood, but the key to beating your cancer might just be in yours.
Okay, thank you. I hope that gave folks some background about this. And again, the focus of that presentation was largely around leukemia and blood cancers, where this technology has really had the most
Good morning. Thank
success.
you for joining me today. I'm going to be going over with you CAR T cell at UCLA, engineered cell therapy programs being driven.
I think what this session will focus on largely is where we're at with neuroblastoma and some of the challenges we faced in adapting this technology that has worked so well for blood cancer, specifically acute lymphoblastic leukemia, and how do we adapt that to solid tumors like neuroblastoma. So I think, Crystal, would you mind leading us off with your group's work on this problem and where we're at?
Wonderful. Okay, thank you, Naveen, for the great introduction. It's a pleasure to be here, part of this distinguished panel, and really like the idea of providing a venue such as this for parents, family members, and advocates to learn more about what's hopefully coming down the pike, or maybe sometimes already newly available for children with neuroblastoma. Can everybody see that and hear me okay? Okay.
Yes.
You know, I'm going to talk about a clinical trial that we have called GD2 Persist. And what this is all about is exactly what Naveen said, trying to take the success of CAR T cells that has been realized against childhood leukemia and bring it to bear on neuroblastoma. And in that arena, our feeling is that while we've tried to do this already, and we'll talk a bit about the data that's already been generated, we think one of the reasons it hasn't been as effective as it could be is that the CAR T cells that we've given for neuroblastoma haven't persisted. You saw in the video that they said that these sometimes persist for a long time. And it's our belief that for neuroblastoma, we're going to need these things to persist for probably some months. And so far, we think that's been a limiting factor in the activity. And I'll take you through why we think that is. But, you know, just to kind of highlight how transformative the results in leukemia have been, because without them, we wouldn't even have the option here to be talking about bringing this therapy to bear. Emily Whitehead is the young lady that received the first dose of CD19 CARs, the first child to receive them at Children's Hospital Philadelphia when she was 6. And the remarkable thing about Emily's cells is that they were one of those long-acting versions. They persisted in Emily's system. And here she is, I think, at the age of 12. You can see she's kind of grown up into a tween, I guess. And her CAR T cells are still circulating from that infusion of 1 bag back in 2012. And that's what we really want to have, especially for solid tumors. And these cells worked quite well in Emily and in many other children, and it led to the first FDA-approved cell therapy for the treatment of cancer, which, you know, people have been working for decades, mostly in melanoma, and nothing was ever good enough. But here it turned out that it was in childhood leukemia that it crossed that finish line. It was also the first gene therapy approved in the United States. Remarkably, it was approved in children prior to adults. And still today, we do not have a CAR T cell therapy approved for adults with leukemia age 20, greater than 26 years. Because it worked so well and it was quite expensive, the company offered an outcome-based payment model, which was the first time anything like that had ever even been seriously considered in the United States, where the company would only receive reimbursement if the therapy worked. And although the patients that were originally treated, of course, you might expect, were pretty far advanced in their disease, because of the promise of this therapy, we, the community, the Children's Oncology Group, is already testing whether we might be able to bring this new type of therapy to bear for children much earlier in the course. So by all accounts, this really was a watershed moment. And I just kind of in my own career have experienced, you know, the changing of hearts and minds as you think about CAR T cells, because before CD19 CAR was demonstrated to be, you know, irrefutably effective, when we would go and talk about this new type of therapy, people would say things like, well, it'll never work. And even if it did, how could you commercialize it and give it to all patients who needed it? And besides, bispecific antibodies do the same thing. Why do we need these complicated cells? And we know our patients are already so immunosuppressed. Their immune systems have been so beat up. There's no way you're going to be able to make cells that work from these patients. And even if you were, it would take too long and the disease is going to progress. And by the way, it's too expensive. And where we are today is that most of these have really fallen away because, frankly, the thing outperformed the expectations of everyone. But we are still left with a challenge around cost, that it's too darn expensive. And that it's, because it's expensive and it's complicated, it's difficult to figure out how, especially if we extend this to other diseases, how are we going to make products for everyone who needs it. And one of the thoughts is maybe you could make them from a super donor or something. But so we're at a point now where people kind of are accepting that this is really something that we all need to invest in. And even the general community is beginning to be open to the idea that maybe this could work for solid tumors. Now, this is you know, a review that we wrote that showed how rapidly, because really the first patient that received the CD19 CAR, there was an adult who received it in 2010 at NCI. Emily received hers in 2012. What we saw was in a very short period of time, we went from one patient receiving this to more than 300 CAR T cell trials. And the FDA approvals happened in 7 years after that first patient. So things progressed incredibly rapidly. And here we are in 2020, and we're staring at a set of challenges. And one part of the challenges are the biologic challenges, the reasons these things fail, and why they haven't worked yet for solid tumors. And that's what all of the investigators on this panel are working hard on. But equally important are the manufacturing challenges, because even if we create the best possible CAR T-cell therapy today for neuroblastoma, the truth is we're going to have difficulty providing that to all the children who need it. And so the field needs to deal with both the biological challenges, but also the logistic challenges of this new type of therapy. Now, despite these challenges, you know, people are betting on the field. We only have really 3, now we have 4 FDA approvals. But arguably, this is the area of greatest investment and research in all of cancer medicine, because the promise is so great. And the FDA said last year that they anticipate that by this year, they would be receiving more than 200 requests to test new therapies. They already had an 800 new therapies that were already under testing. And they think by 2025, they'll be approving 10 to 20 new cell and gene therapy products a year. So even though this is an area of great challenge, people are betting on it. And this is also an outdated slide, but it's basically showing you all the companies that are in this space who believe that if we can get the therapy to work, we can turn it into medicines that can be delivered to patients, you know, using the private sector model. And one of the reasons why people are optimistic is that there's a lot of investment in making the manufacturing more streamlined, more efficient. And basically this comes down to automated platforms or robots. And so as you heard, right now we're making products from each individual patient. This is so-called the Miltenyi prodigy. Miltenyi is a German company who has been a leader in this space, and this is what we're using at Stanford. Each one of these little machines, you put the cells in on day 1, and voila, on day 7, they come out the other side. You've got a CAR T-cell product, and you can line up multiple of these in a big ballroom. This is another model system being developed by Lonza, where you're calling these are called cocoons, and they keep the cells warm and rock them and monitor them at a very high level. And you could see that the cocoons could allow for unprecedented scale up. So we think that despite all of these challenges, that there is reason to be optimistic. And I believe that for the next 50 years of biomedicine, cell and gene therapies, both in cancer and outside of cancer, are going to be the area where we see the greatest advances. This is a review we wrote highlighting all the ways in which investigators are working to make these things more effective. The toxicity was mentioned on the video. There's lots of work underway to reduce toxicity. My lab has been very interested in making these cells work longer and be more persistent. And we think that that's, we'll get there by overcoming a process called exhaustion, when the T cells are just asked to do too much work and they start to peter out. We're also working hard on the persistence, as I mentioned, but there are other issues that lots of smart people are working on. So with that as a background, CARs have already been tested for neuroblastoma. And I wanted to give the historical perspective here, because really the credit should be given to Baylor, where the original GD2 CAR was first tested way back in 2008, before Emily Whitehead received her cells. And what Malcolm Brenner's team did with Martin Poulet, who is now an investigator in England doing incredible work, is they showed that the antibody that's used in dinutuximab, the piece of the binder, could be incorporated into a CAR, and this was an early stage CAR, and they could express that, and tested this in a trial in children with neuroblastoma, and it was so-called a first-generation CAR. It didn't expand as much as we currently can get it accomplished today, and it didn't persist as well, but nonetheless, it was safe, and it showed activity in a small number of patients. You'll hear work from Dr. Hexie today. A subsequent study was also led by Malcolm's group with Andres. And now we have a third generation CAR. It went from a first generation to a third generation, basically putting in stronger domains to fire these cells and make them stronger and hopefully more potent. Unfortunately, it didn't look like things worked any better, and we were very confused as to why that was the case. And at NCI, at the same time around that the Baylor group opened this trial, we actually split the vector with them. And this just is further evidence, just I'm sure that our community already realizes that we work very closely with our colleagues. While we're all working on the same things, we're collaborating wherever we can to try to advance the field. And we collaborated with Malcolm by splitting this vector, and we put it into a trial at NCI. And we basically saw the same thing, that we had made the cells more powerful, but they didn't work better. So what was going on here? And what my lab had discovered, and it took a long time because we were really scratching our heads for a long time, as to why the GD2 CAR didn't work as well as the CD19 CAR. The CD19 CAR was the one that Emily received. And we always want to compare things to that because it's the gold standard. So this is an experiment we did in mice where we took the CD19 molecule, which isn't normally expressed on a sarcoma, we put it there. And we did it because we wanted to compare the potency of this 19 CAR and the GD2 CAR. And the truth was the 19 worked great and the GD2 didn't work. And so we said, what is wrong with the GD2 CAR? And we took a picture of it where we made the CAR molecule glow. And we saw that the GD2 CAR clumped up on the surface of the cell, whereas the CD19 CAR distributed itself very beautifully. And we think that this problem with the GD2 CAR is one of the reasons why, when the Baylor group made it more powerful and when we used their version, we didn't see better activity, because what's happening is this GD2 CAR is signaling and firing all the time, even when there's no antigen around. And I don't expect you to understand this, but basically you see this little black line here? This means this cell is firing even when there's no antigen around. And if you look at the CD19 CAR, it doesn't do that. And when cells fire too much, they get exhausted. And that's just a fundamental principle of immunology. If we ask our immune system to do too much, it gets tired and it starts to shut itself down. And when it gets exhausted, it expresses all of these molecules called checkpoints. And what we learned then was that this GD2 CAR, if we made it fire too much, it actually ended up hurting our cells. And so we found that if we changed the way we constructed the CAR, and we removed the CD28 was the way we were allowing it to fire, and we replaced it with another molecule called 41BB, we made the GD2 CAR work better. And I'll just show you here, these are some mice being treated with either the CAR that has the 28, which the tumor kept growing, or the CAR that had the BB, the tumor stopped growing. So we really thought that we needed to basically make these cells more potent if they were going to have activity against neuroblastoma. And one way of doing that was by substituting the way the CAR is signaling, the way we did it the first time around, or I guess the second time around, and make it the 41BB that allowed these cells, gave them less exhaustion. Another thing we're doing to address this problem of exhaustion is we're manufacturing the cells a little differently. We found that there's this molecule called dasatinib. And dasatinib is a drug that pediatric oncologists are very used to using because it's an FDA-approved drug for leukemia. And we found that dasatinib actually can shut CAR T cells down. And it does it very temporarily, but very potently. And one of the things we want to do is we want to shut these CAR T cells down so they don't get exhausted, especially during manufacturing. And so what we've been doing is manufacturing our CAR T cells, the GD2 CAR, in the presence of dasatinib. And you can see here are animals that have received the GD2 CAR cells that are grown the regular way, and the tumor ends up killing the animal. This is the animals, what percent of the animals survive. And you can see in the black here, the control, all the animals die. And these are the groups where we're making our CAR T cells with dasatinib. And if we give dasatinib long enough, shown in the green and the blue, we can take these CAR T cells and just with that maneuver, make them more potent and able to cure the animals. And here, what we're showing is that we can actually grow those cells in dasatinib on the Miltenyi prodigy, and it works well. So this is a small scale experiment in the lab. This is an experiment which is at clinical scale. And you can see that when we add dasatinib again, this is a killing assay. The dasatinib cultured cells kill cells better than the non-dasatinib cells. The other thing that we're doing to make these cells hopefully acceptably safe is we have integrated a suicide domain into the CAR T cell. And we didn't develop this, but this was developed by a company called Bellicum, again, working in partnership with the folks at Baylor. And what we know is that if the CAR T cells are too potent, they could cause toxicity. And this is a system whereby there is a suicide molecule there that can be turned on by a small molecule that we can give our patients if the toxicity gets too great. Now comes the rolling out of the trial. So now we've spent the last almost 5 years working to optimize the CAR T cell. And I should mention the Society for Cell and Gene Therapy for Cancer had provided us some funding to do that work. But now we have to roll out a trial, and these trials are very expensive. And one of the problems with CAR T cell therapies is most of them are being delivered at one institution and not available at multiple institutions, which really makes it difficult for all children who need it to access these therapies. And so one of the things that I've been working with very intently is with our investigators at these institutions in North America to launch a new clinical trials network called the Pediatric Cancer Immunotherapy Trials Network. And I want to say that this was launched by the Cancer Immune Shot program that Vice President Biden launched during his career in the White House, really in memory of his son, Beau Biden. And part of the Moonshot program was to start a clinical trial network where we could deliver immunotherapies for children's cancers. And so this network has now launched, and this is the network through which we are going to do the GD2 CAR Persist trial. And the trial is seeking to determine whether we can manufacture the cells. As I mentioned, manufacturing is a complicated issue, and we have to get the cells from the patients, ship them to the manufacturing site, ship them back. We're doing it in the Prodigy. We're doing it with dasatinib. We want to determine the safety and the appropriate dose of the cells. We want to determine whether the cells have clinical activity and whether they persist. And importantly, the National Cancer Institute is sponsoring this trial. They're providing the coordinating center in Seattle. They're doing the manufacturing and distribution in Frederick, Maryland, and they're doing the monitoring. And the overall cost of goods and services provided by the NCI in support of this trial is more than $5 million. So this is a huge investment by the National Cancer Institute in the next generation of therapies for pediatric cancer. We're also planning a strategic alignment with the NANT sites to open the study at NANT sites. It's one of the things we can do with the Cancer Immunotherapy Trials Network, and to conduct some of the scientific studies in collaboration with NANT. And so this trial will be one of the first to demonstrate the feasibility of an academic multi-center trial of engineered cell therapy for pediatric cancer. And so we think that it is a really important trial, especially for that reason. And I'll stop there.
Great. Thank you so much, Crystal. Next, I think Professor Locatelli is going to share his work in Italy and his thoughts on this challenge in neuroblastoma.
Hello, can you hear me? Yes, yeah. I suppose. Good morning to everybody, and thank you so much for inviting me to present our experience on the use of CAR T-cell and children with neuroblastoma. And certainly my presentation has been greatly facilitated by the two previous talks, in particular that given by Crystal, because she provided the basic concept responsible for the development of strategy based on the use of CAR T cells targeting antigen express on the cell surface of neuroblastoma element. And just to start my talk, there is certainly one crucial point that was emphasized in Crystal's talk, namely that the challenge offered by the solid tumor is much more difficult to be beaten in the context as compared to the context of hematological malignancies. And there are several reasons responsible for the lower efficacy of CAR T cells and solid tumor, already briefly mentioned by Crystal, namely the identification of a suitable target antigen selectively or preferentially expressed by tumor cell. There is the issue of the penetration of the CAR T element in the tumor mass, not to talk about the mechanism of tumor escape deriving from the immune depotentiating activity of tumor microenvironment. And all in all these factors certainly contribute to reduce the long-term persistence of CAR T cells. In view of all this consideration, we decided to invest on what can be called a third-generation CAR construct targeting GD2. Indeed, we reasoned that adding not one but two costimulatory domains could improve the efficacy of CAR T cell in solid tumor and in particular in neuroblastoma. And thanks to a very extensive preclinical work that we published some years ago, at the end of the day, we concluded that the combination of CD28 and 4-1BB as costimulatory domain is associated with the best efficacy, at least in our preclinical models of CAR T cell targeting GD2. And we decided to use a retroviral platform, including also the same CPTs which already commented and presented by Crystal, because we have a collaboration with the Belgian pharmaceutical as well. So our construct is a third-generation CAR with the suicide gene, including CD28 and 4-1BB as costimulatory domains. And indeed, these are the data clearly demonstrating that in the animal model, this combination of costimulatory domain is associated with the remarkable anti-tumor efficacy. We decided to design a phase 1 and 2 trial in which, in the phase 1 portion of the study, we included patients that have already failed conventional frontline therapy and are judged to be incurable. While in the phase 2 portion of the study, we decided to open the enrollment also to those children with a high-risk neuroblastoma, considered to be exposed to a very high risk of tumor recurrence. And the age range is comprised between 12 months and 25 years. And all these patients must have a Karnofsky or Lansky score of at least 60% for being included into the trial. We also decided to have an escalating, de-escalating model for running the trial, hypothesizing to use 5 different dose levels and starting at the dose level 3 with the possibility of increasing to the dose level 4 and 5 in case of absent toxicity, or de-escalating at the dose level 2 and 1 in case of dose-limiting toxicity. So it's a classical dose finding 3+3 design, and has already mentioned by Professor McCall during her beautiful presentation, we also decided to administer a lymphodepleting chemotherapy in order to promote the homeostatic expansion of the CAR T cells. And the reason for doing this is that there are several papers clearly indicating that this lymphodepleting therapy is crucial for promoting the expansion of CAR T cells. We have run the phase 1 portion of the trial, and I anticipate that we didn't record any dose-limiting toxicity. And we have already included 10 additional patients for a total of 19 children in the phase 2 portion of the trial. As you can see in this slide, all patients had a metastatic disease at time of diagnosis. Many of them had a MECAN amplification, also representing another important risk factor for treatment failure. And indeed, all patients but one included in the phase 2 portion of the trial had failed between 2 and even 5 lines of treatment. Moreover, in all patients but one, there was a measurable disease at time of the infusion. As I mentioned before, we didn't record any dose-limiting toxicity during the phase 1 portion of the trial, and thus the recommended dose that we are now infusing is up to 10 million of cells per kilogram of recipient body weight. And the main toxicity that we observed was related to the use of the lymphodepleting chemotherapy. Only 2 patients experienced the hyperinflammatory state presented in the video about the Leukemia Lymphoma Society. In particular, one patient each developed a grade 3 and grade 4 toxicity. And we decided to activate the suicide gene exactly in the patient who experienced the grade 4 toxicity, because the control obtained with the pharmacological therapy was really partial. And looking at the data that are presented in this cartoon, let me draw your attention on the fact that we recorded a very nice expansion of the CAR T cells that in some patients accounted up to 90% of the whole number of T lymphocytes in peripheral blood, and the infusion was associated with the production of cytokines typically observed in patients given CAR T cells for either leukemia or B-cell non-Hodgkin lymphoma. And when we look at the presence of the GD2 CAR T cell at the tumor site, we were able to demonstrate that these cells are able to migrate in the tumor site where there is a predominance of the so-called cytotoxic lymphocytes, namely the CD8 positive CAR T cells. And looking at this slide, reporting now the maximal clinical response, I am glad to share with you that we observe an overall response rate approaching 80%, and 7 out of the 19 patients either obtain a CR or in one patient treated with non-evidence of the disease, we were able to maintain a complete absence of the tumor signs and symptoms. And also giving you an idea of the results that we obtain, let me share with you some radiological images. This is an MRI demonstrating that 6 weeks after the infusion of CAR T cells, we observe a shrinkage of the lymph node metastasis with the presence of area of necrosis and colliquation. And the CAR T cells were able to resolve also lytic lesions, metastatic lytic lesions, at the parietal bones. And looking at the MIBG scintigraphy, you can easily observe in this cartoon that at week plus 12 after the CAR T cell infusion, there was a very nice clearance of the multiple bone lesions that were present before starting the pre-CAR T cell infusion lymphodepleting chemotherapy. Finally, Crystal has already mentioned that the GD2 is expressed also on tumor elements of other neoplasias, including sarcomas of the bone. For this reason, we decided to amend the protocol and to infuse our 3rd generation retroviral CAR T cell in 2 patients, one each affected by Ewing sarcoma or bone sarcoma. And you can appreciate that in the patient with the Ewing sarcoma, the infusion of CAR T cell was able to obtain a nice resolution of almost all the disseminated tumor lesions, and in the patient with the osteosarcoma, the treatment with CAR T cells was associated with the disappearance of the metastatic lesions in the costal ribs, as well as in the lung parenchyma. So we are still recruiting patients. We will expect to complete the study recruitment in roughly less than 1 year from now. And then we will have the opportunity to draw definitive conclusion about the long-term efficacy of our approach. And thank you again for offering me to present this data.
Thank you so much. That is incredibly exciting. Andras, I think we were going to hopefully see your group's work at Baylor and an update on.
That's good.
Thank you so much.
Well, thank you everyone for this wonderful opportunity to be part of this really impressive panel, and of course to present to the families and advocacy groups. It's an honor to be here. So I wanted to give a quick update on the work that's being done at Baylor College of Medicine. I just wanted to mention that I do have some conflict of interest. I do have patents related to some of the work that's going to be presented, specifically the NKT cell related trial. So going back to Baylor, with the leadership of Malcolm Brenner, as Krista McCall mentioned, the group here has been working on CAR T cells for about 15 years. Of course, some of the investigators now in the UK, like Martin Puley, but we continue to work and try to find effective ways to treat children with neuroblastoma using CAR T cell based approaches. Right now, there is at least 2 groups that are specifically focused on developing engineered cell-based therapies for children with neuroblastoma. And there are 2 ongoing clinical trials that I just wanted to introduce and show some of the emerging results. One is focused on T cells expressing GD2 CAR and a constitutively active IL-7 receptor. The PI of the study is Dr. Bilal Omer, but he was kind to share a couple of his slides, and so I was hoping to show you some of the results there, although that study just recently opened. And the other trial that is being conducted is engineering natural killer T cells, and I'll describe why these cells are different and why they are potentially have some special promise for neuroblastoma therapy. And these NKT cells, for short, express a GD2 CAR with interleukin 15. This is another phase 1 study, and I'm leading that study currently. So first, just to introduce the GD2 CAR T cell trial that is combining CAR T cell therapy with the expression of an IL-7 modified IL-7 receptor. And I won't go into the details of CAR design, but as Dr. McCall already mentioned, it's critical to find the receptor that works best for the cells and doesn't actually harm the cells. This receptor indeed incorporates a 4-1BB endodomain. In addition to that, the cells express this engineered receptor. So we talked about that the receptor design is important, which provides signal 1 for effective T cell activation. And in the newer generation of receptors, in addition to the signal 1, signal 2 for so-called costimulatory molecules is also incorporated. So when CAR T cells see a tumor, they will get 2 signals at the same time, which is closely resembling what would happen under physiologic conditions. It's not the same, but getting to it. Another perhaps important aspect of T cell activation is getting signals from cytokines. And many of these cytokines are lacking in the tumor microenvironment of cancers, including neuroblastoma. So what are these cytokines? So for example, IL-7, interleukin 7, or interleukin 2, interleukin 15. These are all important for T cell survival, expansion, persistent maintenance of proliferative capacity, and some other important aspects of anti-tumor properties. So how can we provide these signals to CAR T cells? So one way is to engineer one of the receptors to constitutively, so continuously fire, and thereby providing the signal 3 fuel, as Bilal describes it, to GD2 CAR T cells. So the GALAN trial, which is using this strategy, is having this engineered interleukin 7 receptor incorporated to T cells in addition to GD2 CAR. So in this case, the T cells are getting signal 1 through the CAR, signal 2 from the costimulatory 4-1BB domain, and signal 3 by the engineered interleukin 7 receptor. This trial enrolls in the kind of standard 3+3 design and treats patients on 3 dose levels. At the beginning, when patients are referred, it takes about 4 to 6 weeks to generate these products, but peripheral blood is enough to make these products. And after baseline imaging and kind of baseline disease burden assessment is completed, if the product is made, patients receive lymphodepleting chemotherapy with cyclophosphamide fludarabine, and then are being infused by on one of the dose levels with the GD2 CAR C7R cells. And after 6 weeks, during which time the patients are monitored here at Baylor, a disease assessment is performed. And of course, during these 6 weeks and even after that, samples are taken to monitor the expansion and persistence and evolution of the CAR T cells in the peripheral blood. So the aim of the study, as I mentioned, as I should mention, is safety. Then, of course, evaluating the expansion and persistence and anti-tumor responses. Thus far, as far as safety, which is the primary objective of the study, 5 patients have been treated after lymphodepletion on dose level 1, and 3 of these patients were osteosarcoma patients. 2 had neuroblastoma. The side effects included mild to moderate cytokine release syndrome, as Navin mentioned at the beginning, or showed the video at the beginning of this session. Cytokine release syndrome is something that is often seen in patients who receive therapy with leukemia, and it's not necessarily a bad thing, but it's important for the patients be monitored and treated soon to make sure that this cytokine release syndrome doesn't kind of get out of control and cause more than necessary harm, if harm is at all necessary, of course. So one patient did have a grade 3 cytokine release syndrome, which means that a patient obviously was in the hospital and required substantial support to maintain its blood pressure, and required even steroids to control the cytokine release syndrome. Importantly, there was no neurotoxicity seen, and because of this effect, now patients who start with a fever will be receiving anakinra, which is a mediator of cytokine release syndrome that can be used for patients quite early on the GALE-N trial. The osteosarcoma patients that were treated on this study had stable disease, and the 2 neuroblastoma patients who were treated on dose level 1 after lymphodepletion also had stable disease, but based on the International Neuroblastoma Response Criteria, when we look a little bit closer, both of these patients had a slight decrease in their Curie score, which does cause give some reason for optimism since this is just on dose level 1. And as Bilal is increasing the doses, obviously the hope is that more effectiveness will be detected. And when it works, this is what it looks like. So this is what Bilal sent over, one of the tumor areas shown here by an MIBG scan. Before the infusion of CAR T cells looked like this, and then after the infusion, that MIBG-avid area seemed to have completely disappeared, which is quite promising. So I would like to shift next to the GenaKit-2 trial, which is evaluating NKT cells which express a GD2 CAR and interleukin-15. In this case, signal 3 is provided by interleukin-15. So just as with the GALE-N trial, the idea here is that all three signals are provided for the effector cells to expand, persist the most. This is a very simplistic view of neuroblastoma, obviously, but I wanted to introduce that neuroblastoma is not only cancer cells. There are a lot of other cells in there that are often supporting the cancer to grow and provide immune suppression. Additionally, that would turn on CAR T cells or CAR NKT cells. So why is this relevant in the context of neuroblastoma? So we know that tumor-associated macrophages, which are a type of white blood cells, when they are present in larger numbers in neuroblastoma, those patients have poorer outcomes. Well, it turns out that these tumor-associated macrophages support neuroblastoma growth by various methods. And what's interesting is that NKT cells can recognize tumor-associated macrophages and can attack these tumor-associated macrophages. In fact, the presence of NKT cells in children with neuroblastoma is correlated with better outcomes. And this is through this indirect mechanism of tumor control via tumor-associated macrophages. The question is obviously, well, okay, NKTs have this innate properties, but can we actually redirect them to target tumor cells? So that's when the GD2 CAR comes in, which then redirects NKTs not just to kill tumor-associated macrophages, as shown on the higher area of this schematic, but then NKTs can also target cancer cells directly, which in the ideal conditions should lead to the destruction of cancer cells and, of course, the expansion of NKT cells to provide, CAR NKT cells to provide more effector cells to get rid of, in the ideal condition, the whole tumor. So the GINA-KIC2 trial is enrolling only relapsed and refractory high-risk neuroblastoma patients. These children also receive lymphodepleting chemotherapy with cyclophosphamide and fludarabine on day -4, 3, and 2. And then the cells are infused on day 0. And with the currently, the study is enrolling on 4 dose levels, well, escalating up on 4 dose levels, and we are already enrolling on dose level 4, with the primary objective of defining safety of this approach, understanding the persistence and trafficking of NKT cells, and then on the anti-tumor responses. As I mentioned, similarly to the Galen trial, when the patients are referred for the study, it will take about 4 to 3 weeks to generate the product. After that, if the product is available, then the cells can be infused. It's only after only 4 weeks is when we evaluate the disease response, and there are weekly visits for monitoring, and there is a biopsy of any involved site at week 2 to understand what's happening in the tumor microenvironment and trying to find these cells and see how they have evolved post-infusion. One thing that here apheresis is required, and currently it's only it can only be done at Texas Children's. So there's 2 trips for this trial. The first one is quite short. The second one is a little bit longer because of the requirement for 4-week monitoring. So we enrolled 10 patients thus far on the study, 3 on the first, each 3 initial dose levels, dose level 1, 2, and 3. All of these patients had stage 4 disease. Many of them had really widespread disease with very high Curie scores. And most of the metastatic sites were obviously bone and bone marrow. Thus far, the infusions have been safe. We have not had any patients that triggered dose-limiting toxicities. And most of the grade 3, grade 4 toxicities were related to the lymphodepleting chemotherapy. As shown here, this is expected. And we did have some patients with fever and neutropenia, and we did have cytokine release syndrome on this study as well. One patient did require the administration of tocilizumab, but did not require any support for blood pressure. The anti-tumor activity is something that we are hoping to now further increase on dose level 4. We did have 2 patients with stable disease, 5 patients with progressive disease, and 2 patients who had a partial response. But again, if you look into one of these patients who had stable disease, that was also, if you look at the Curie scores, was also some cause for optimism, as the Curie score did actually increase, although that doesn't trigger response based on the International Neuroblastoma response criteria. So when it works, it does seem this approach seemed to work quite well. This is one of the patients who had a pretty well-defined lesion in the sternum, and before infusion, it was lighting up quite heavily. After infusion at 4 weeks, the cells actually expanded quite well in this patient. The lesion has shrunk, or it actually had decreased MIBG uptake. And after an additional 4 weeks of observation, during which the patient did not receive any other cells or any other therapy, there was a continued resolution of the lesion, which obviously we were quite excited about. So with that, I just want to point out that Leonid Metalitsa is working with me on the GeneAcute-2 study, and Bilal Omer is leading with Cleo Rooney and Malcolm's group the GALE-N study. And I think after this, Naveen, we might be going straight to the Q&A, so we'll take the questions right there. But obviously, I thank all the funding sources for and the support of families and referring physicians.
Great. Thank you, Angash. I think, Nick, are you going to host the Q&A session, or is?
Sure, thank you, Naveen. Thank you for our speakers and those really interesting talks on CAR T-cell therapy and ongoing clinical trials. We have a few questions. If anybody that's watching wants to post some additional questions for our speakers, then just use the Q&A box at the bottom and we'll try to get them answered. So we've got a few questions. One for all the speakers. How easy, difficult is it for a child to participate in any of the mentioned trials remotely, provided their clinic already has a T-cell therapy center? Is it possible for clinics to cooperate amongst the clinics?
I can take that. This is the challenge of the therapy, really, in essence. And it's why I spent, a good deal of time focused on the fact that the scientific breakthroughs in this field have to be in tandem with manufacturing and regulatory breakthroughs. Because there is no way for a child who is not enrolled in one of these trials to receive the therapy because of the complexity of it, the expense, and the regulatory requirements. And so if, you've seen some amazing results presented here today, in particular, Dr. Locatelli's results, to see those kind of response rates in a solid tumor, it really could be our next watershed. And if that's true, that's beyond fantastic. But it also requires that the field figure out a way, if it's true and if it's safe, that we can deliver it to all the children. And this is where the advocacy community, I think, can help us. Because there are many factors that will go into making these things available. Some of them are the regulators, the EMA and the FDA, and some of it is the private sector. Some of it's figuring out whether there are ways for our children's hospitals to be able to be permitted to manufacture these cells rather than just having them manufactured at a factory. So it's a long conversation worth having. It's moot unless we get active therapies, but as you can see, we're on the verge of seeing active therapies. So it's going to become a real issue going forward, I think.
Maybe Professor Locatelli, can I, following on from that, can I pick up the point with you with regards to the trial that you're leading at your institution? What's the plans for that trial beyond the expansion cohort, and other plans to expand that within Europe, talk to some of the cooperative groups that run trials across Europe?
So many thanks for asking this important question. And by the way, let me, because I forgot to do this at the end of my presentation, let me acknowledge the great collaboration with Malcolm Brenner and his group, because we started together this program some years ago. This trial indeed is already recruiting patients treated in different Italian centers. In other words, it is true that all children were treated here in Rome at the Bambino Gesù Children's Hospital, but these patients were referred by other Italian institutions. One completed and validated the idea would be that of proposing in the European context the approach, provided that the results, of course, will confirm promising. But it's very important to underline from my perspective the importance to establish even transoceanic collaboration, for example, with the group of Crystal or the group of the Baylor, because in the context of such a rare disease, exchanging ideas, information, protocols is absolutely crucial to optimize the patient outcome.
Thank you. I have a question that Dr. Merkel wants to take. Because the CAR T cells are anti-GD2 and they're replicating in the body, is there a risk over time that they start attacking nerve cells and inducing pain?
Andres, would you like to start the response, and then I can further complement if you wish?
Hold on. Could you please repeat it?
Sure. So the fact I think this is related to the notion of anti-GD2 therapy.
Yeah.
And we've heard earlier in the meeting that one of the side effects of anti-GD2 therapy is that because GD2 is also expressed on peripheral nerves, and it causes pain.
Yeah.
So I think the question is, with CAR T cells, and particularly if they work and therefore persist within the body, and they act against GD2, is there risk of toxicity in the long term and this kind of nerve damage?
So we thus far haven't seen any significant pain-related issues in any of the patients, which can be, for several reasons. Maybe the CAR T cells or CAR NKT cells are not expanding enough, and if they are not working against the tumor, why would they work against peripheral nerve sheets? The other reason is I think perhaps that the mechanism by which pain is triggered in the peripheral nerve sheet is more complement dependent. So it may not be a potential side effects of CAR T cells, but nevertheless, I think we just have to monitor these patients and make sure that responses are arriving, because we are increasing the doses and making products that have more potent CAR T cells or CAR NKT cells in them, that the pain-related side effects don't appear. Thus far, it hasn't been a problem in any of our trials.
Wait, sorry, when you say complement dependent, are you talking about the fact that CAR T cells use different parts of the immune system than anti-GD2 therapy?
Yes.
If I may comment on this issue, and just to reassure the person who raised the question, to the best of my knowledge, so far the toxicity has been, generally speaking, manageable. In our hands, no patients had long-term sequels related to the use of GD2 targeting CAR T cells. And although they expand very nicely and they persist for some weeks after the infusion, on the long term, they disappear.
Thank you.
This is just to build on that. We, 8 or so years ago, developed a CAR T-cell trial in Seattle, led by Julie Park, which I've sort of taken over it with this theoretical concern. I agree with the group that we haven't seen any GD2 related pain on any of the trials that have been presented today, which is very encouraging, especially because we've seen some activity, anti-tumor activity. But another potential way to work around that is to select other antigens that are present on neuroblastoma and potentially not present on normal cells. And so at Seattle Children's, we have a CAR T-cell trial targeting a different neuroblastoma associated protein called L1CAM or CD171. And that's our ENSIGHT trial. And so similar to all the trials that were presented here, the process is very similar. And we're evaluating this target in patients with relapsed and refractory neuroblastoma. I think similar to some of the presentations today, we haven't seen the same exciting activity that Dr. Locatelli presented or that the leukemia folks are seeing. But we are seeing in some cases that the CAR T cells are able to infiltrate the tumor. We're seeing some patients develop a syndrome that we've called pseudo progression, where at sites of known disease, there's swelling, redness, pain. And in a couple of cases, we've biopsied those patients and shown that that is related to the CAR T cells infiltrating. Unfortunately, for the same challenges that everyone else has presented, we're not seeing long-term persistence of our CAR T cells yet. We're still escalating the doses and working on some additional manipulations of the engineering technology to hopefully make them last longer. But I think some of the highlighted challenges go beyond the target that you're selecting or solid tumor specific, where we really need mechanisms to get these CAR T cells to stick around for a longer period of time.
Thank you. So I've got another question, and this is relating to antigens. In respect of CAR T cells, is GD2 a good enough target to have CAR T cells that really work in children with neuroblastoma?
Well, I think, as Naveen pointed out, there is a lot of activity looking at other targets. L1CAM is one, B7H3 is another. We've tried to develop one to ALK, DLL3. So I think the academic community is aware that putting all your eggs in one basket might be a problem in the long run. But right now, GD2 remains the lead contender. So.
Anybody else have any?
I fully agree with Crystal's comment. B7H3 is another potential target. We are also working on this alternative, but she's absolutely right. GD2 still remains probably the best target at the moment.
We also have opened a B7H3 CAR T cell trial and have now treated 2 patients on that trial. The first patient was actually somebody who had previously been treated with our L1CAM CAR T cell and actually got several infusions because they had had stable disease in response to those infusions. Who knows what that actually means, whether there was any anti-tumor activity or not. And now we're very early in that B7H3 trial, obviously, but that patient, again, had stable disease after progressing, several months after their last L1 CAM CAR T-cell trial, enrolled on the B7H3 trial, and 6 weeks into their infusion has stable disease. Probably also had some signs of this pseudo progression where she had tumors at multiple sites that became painful about 2 weeks after the infusion, and then that pain gradually subsided over the following weeks, and that was not due to progressive disease on scan, so everything was very similar, and that patient is coming back in a few weeks now, 3 months after their infusion for follow-up.
So if a patient enrolls on one CAR T-cell trial and then goes on to another one, do they start completely from scratch and have their cells taken out by apheresis and engineered all over again?
So it's a great question. It sort of builds on the first question, and it depends. This patient actually had enough cells collected in their first CAR T-cell harvest or apheresis procedure that it allowed them to enroll on both trials without a subsequent collection. So that is possible. And oftentimes, I don't know if this is the case at other centers, but oftentimes we collect more than enough T cells to allow for either multiple infusions of a T cell that may be working but not persisting, or to enroll on multiple CAR T cell trials. So that being said, we have also had patients who have exhausted their CAR T cells with their first infusion, and if they were to enroll on a subsequent trial, would have to have a second procedure to collect T cells.
Okay. There's another question here. Can allogeneic cells be used in order to provide easier off-the-shelf access for mass production availability to all patients in the future? I don't know who wants to take that one.
I'll take it. Obviously that could solve our manufacturing challenges if it were to work. And it should reduce the cost as well. So I think the field is open to this. There aren't great scientific reasons to do it. There are more economic and logistical reasons to do it. Some have argued maybe an off-the-shelf might be a better quality product, but I don't know if that's really true. All of that is to say that mostly companies are working on this, and there's a lot of money being poured into making this a reality. My guess is we're going to see some off-the-shelf products come down the pike for liquid tumors first, and those same platforms could ultimately be used in a case like neuroblastoma. But right now, what the data is such that really the autologous have advantages given the technology we have right now, because we haven't figured out a way really to prevent these things from being rejected by our patients' immune systems. That could change in the future, though. So I think this is something, a part of the field we want to watch.
I can add a couple of comments to the comment raised by Crystal that I fully approve and I concur. It can be that in the future NK cell could represent an alternative for two reasons. Number one, because they are unable to cause GvHD, and that's the main barrier for using allogeneic T cells. And because we demonstrated in an approach that we published for CD19 that using a single apheresis, you can obtain a number of NK cells available to treat up to 200 patients, this lowering the cost of the approach. Of course, it has to be demonstrated the equivalent efficacy of NK cells, but this could be an alternative. The other comment that I want to raise is that in our strategic plan for managing children with neuroblastoma, time of diagnosis, we perform a leukapheresis for cryopreserving T lymphocytes just in case to manufacture then CAR T cells, this potentially reducing a little bit the issue of the impairing effect played by chemotherapy over treatment.
Thank you. We have a question here. Which stage 4 patients are considered high risk for relapse even after no evidence of disease in frontline therapy in order to be enrolled for the trial? I think this is directed to you, Professor Locatelli. And
yeah, in our protocol, stage 4 patients with NMIC amplification and with a partial response before surgery, autologous stem cell transplantation were considered at high risk of relapse.
So that means that there's a possibility for this treatment to be used in a minimal residual disease setting as well as against.
Exactly.
That's not the case in any of the other existing trials in North America, I take it.
That's correct.
Question on cytokine release syndrome. How can it be prevented or managed? So, Dr. Hexley, I think you mentioned a patient on one of the trials that you're currently running.
Yeah, so I think currently most of the centers are not yet using prophylactic management. We are responding to it when it occurs. And fortunately, thanks to the work by others in the leukemia community, we now have a pretty good understanding of what is causing cytokine release syndrome and what is at least driving this phenomenon. And the good news is that because of this mechanistic knowledge, we can disrupt cytokine release syndrome with relatively specific drugs. And so we use tocilizumab to block IL-6 or anakinra to block IL-1. And there are some other ways to further disrupt cytokine release syndrome. With these approaches, if cytokine release syndrome occur, and keep in mind, it's not necessarily a bad thing to happen. But of course, we don't want it to go out of control. So if it seems to be getting to a more serious side, then right now I think the therapy is available and quite potent. The leukemia where there's an extra layer that neurotoxicity can occur, which hasn't been shown, at least to my knowledge, it hasn't happened in children with neuroblastoma. So I think right now at least in our group, we are not necessarily thinking about prophylactic use. Maybe early intervention on the Galen trial, for example, is something that is now being explored. But it seems that the treatments thus far have been quite effective.
Oh, Nick, your microphone.
Muted myself. Sorry. Thanks, Larry. I think this is, so somebody's asking what the CAR is being used, and I think they mean in the GD2 CAR persist study, actually. They're asking, is the CAR the same as that being used in Baylor in the trial?
Oh, yeah. It's a 4-1BB only. We removed the CD28, so it's a little different. Andres, yours is?
Well, in the Galen trial, it's also 4-1BB, but I'm not sure about the hinge and transmembrane domains, whether there might be some slight difference, but I think the overall architecture might be comparable. Yeah.
So where there have been seen to be responses in studies which have happened so far, and I think that your talk, Dr. Mackel, was even in the very early one there were 3 patients who responded. Is there anything that suggests patients respond in with disease in particular sites or particular types of disease? Or do we know whether there is any particular type of patient who might be more likely to respond to CAR T-cell therapy?
I don't know if, Andres and Franco may have other, I'm not entirely sure. The only thing I would say is I think that bone marrow disease may be fairly accessible to CAR Ts. And there's been some early signals that bone marrow might be, whereas it's very difficult to clear it with chemo, it might be actually better able to target it with CAR T. But I'd love to hear what Andres and Franco say.
Yeah. So in our experience, the few responses that we had, they were including bones, soft tissue, and bone marrows. It's hard to tell whether one site is going to be more likely to respond just because of the very few numbers. But we did notice, though, that when patients are referred with really, really high disease burden, that is a challenge. And I don't know what the other panelists think, but I think it would be important to offer these therapies relatively early on in the setting of recurrence, relapse, or refractory disease. There are established salvage regimens for neuroblastoma, and there are a lot of potential therapies available, which is on one end is a good thing, but of course, someone with 5 lines of therapy and a Curie score of 25 is going to be challenging to treat.
I can comment that one factor that correlated with a poor response in our hands was an increased percentage of what we call the myeloid-derived suppressor cells. These are a type of cells deriving from the myeloid compartment of the hematopoiesis, and they are known to depotentiate the immune response. In the patient who had a poor response, we found a higher percentage and a higher absolute number in comparison to those who obtain a response.
Is there any, from what you said, Dr. Hexie, about the burden of disease, but the expansion of T cells being infused and then doing their work, is there any relationship between needing to have a certain disease burden in order to get the T cells to actually replicate and do their work?
I think it's hard to know. I would speculate that the lower the disease burden, the more likely that these effector cells are going to be not overwhelmed and make and can make a big difference. If you look at it, that there is an effector to target ratio in this biology, and I could speculate again. It's hard to tell based on the few patients we had that you need a certain amount of extra T cells there to overcome the tumor. Obviously, we are hoping that the infused T cells, NKT cells, go through a robust expansion and thereby, repeated killing of cancer cells in the body. But it would be hard to say if there is a specific cutoff above which or below which these therapies will work. The least disease burden, probably the better.
I think I agree but our leukemia colleagues who have developed really effective CAR T-cell strategies have seen scenarios where patients enroll to get their CAR T-cells and then receive some therapy while their T-cells are being manufactured that sort of really brings their disease level down close to 0. And we have seen in those scenarios that the CAR T cells don't expand very well, and there have been some patients who have then relapsed. So I think it's this delicate balance of needing some antigen present for the CAR T cells to be active, but having a small amount of disease, so there's a good effector to target ratio.
So with all of these studies, if my understanding is correct, this is a one-time infusion of CAR T cells to then see if there is a response, which is kind of generally different from a course of targeted therapy or chemotherapy. Is there any, if there is a response, but then maybe the disease progresses, is there any, or are we going to get to the point where there is evidence for trying to do a second CAR T cell infusion, or doing a CAR T cell fusion of a higher number of cells?
So we've tried second infusions in multiple trials, and in general, they've been underperforming. We don't really know why. We don't know if it has to do with an immune response to the CAR itself or some change in the immune milieu. So theoretically, we could use multiple infusions, but it hasn't been as effective as we might have hoped. So that's why there's so much emphasis on, and plus the cost on getting it right with one infusion.
We've got a couple more questions, and then if we don't get any more, we'll bring the session to a close. So if anybody does have any other questions, please drop them in. We have a comment here that this is one of the most interesting sessions. Can any of the trials run without the depleting chemo that precedes it? Is this always necessary to clear the space for the new cells? And I actually had a question that's kind of as a corollary to that. Is there any research in terms of smarter ways of doing the lymphodepletion without causing what seems to be one of the biggest factors, which is the hematological toxicity as a result?
If my colleagues and friends agree, I can take this question. There are several studies suggesting that the lymph-depleting chemotherapy is crucial for promoting the homeostatic expansion. For the people attending this session who are not ND, let me stress the concept that the intensity of this lymph-depleting therapy is really mild. It's a sort of gentle chemotherapy, not causing any relevant side effects, with the exception of the decrease in the CBC.
So this isn't like the typical high dose therapy that people are used to before they.
No, not at all.
I think most of us presented that the cyclophosphamide fludarabine combination is probably the most utilized lymphodepleting regimen. And just to sort of build on the question, there has been some work in adult solid tumors where using different lymphodepleting regimens, potentially that are more tumor specific. Cyclophosphamide and fludarabine is probably not very active against the neuroblastoma itself. It's really meant to reduce the normal T cell numbers and immune suppress the patient, so the CAR T cells or NK T cells can have some space to grow. And one potential avenue would be to evaluate different lymphodepleting strategies that may also have some anti-tumor efficacy. That's been shown in lung cancer patients to potentially have more activity.
So we've got one final question, and then we'll close the session. Is the goal of MSK's vaccine trial to basically use the vaccine to induce anti-GD2 T cells, or are they targeting a different immune response? Does anybody have a?
I'm sorry, my computer cut out a little there, Nick. Could you repeat? Sorry.
We have a question that is the goal of MSK's vaccine study, so their bivalent vaccine study for GD2, GD3, is that to induce production of anti-GD2 CAR T cells or T cells, or are they targeting a different immune response?
I think that I'm obviously not involved in the development of that trial, but I think the goal is to develop a different anti-tumor response, a humoral or a B cell based response. There may be T cell responses as well, and I think the MSK group is looking at that pretty actively, but it is a similar hope is that you can develop an immune response and a group of cells that will surveil or float around looking for neuroblastoma cells to destroy.
Terrific. Well, thanks very much for our panelists for a wonderful session. Thanks for taking the time to join us, and for everybody that's watching. We're now going to have a break, and we will come back to you with the next session, which is DFMO studies at the Beat Childhood Cancer Research Consortium. So if you go and make your cups of tea, and then head back over to the website for the next session. Thank you very much.
Thank you. Bye.